the name of Allah, Bismillahirrahmanirrahim. It's my obsession to show this slide in our mid presentation. I really mean it, believe you me. It's my obsession, I don't know, but it is there. Please take care of this piece of land, despite you may have a lot of grievances about this. It's my mission statement, and it's me on the slide serving neurology nationally as well as internationally. I have been given a task. First of all, I'm thankful to Pakistan Society of Neurology and Pakistan Headache Society for giving me a task to talk, to share my thoughts, my concept about diagnosis and differential diagnosis of cluster headache and other TACs, that is trigeminal autonomic cephalgias. It was a bit tricky to me, at least, maybe very easy for you people, but it was a very tricky topic for me. It's cluster of headache experts. We were in 2018 when I was the president of Pakistan Headache Society in Korea. So there is always a very good fruits of any presentations. But to me, that I want to give you one fruit of army presentation is either to refresh your knowledge or just to reconceptualize your idea, your concept about the trigeminal autonomic cephalgias. So I think this slide needs your attention. Knowledge is not free, but you have to pay attention. So be attentive for next couple of slides. While it was why I called it tricky to me, because I have to go through in my archives, that through my books, then to my first desktop in 1998, and then to my laptop, and of course today is the era of ChatGPT. And what I find, there was no good vibes out of all this information. There was such as very simple disappointments. It's my own perspective. You may have different opinion from my observation, no problem. Why? They are a particular feature of TACs. They appear fast and they disappear fast. This is one of the most peculiar characteristics of TACs. And honestly, till now, there's no proper RCT available, so you can conclude something. Third is, there's no proper treatment available. Again, I will say it's my own perspective. And fourth is, they are not any in the mainstream of our advanced research. They are not. But what we have, they are the leftovers, any migraine type of problem. They are being used for migraine, they can be used for cluster headache and others, but there's no specific space for advanced research of about the TACs. So this observation is being endorsed recently in 2023. And what they issued that cluster headache is a devastating disorder. And currently available preventive treatments are insufficient for majority of patients with cluster headache. And this statement is not given by a single person. There were a cluster of 5 different headache experts from Sweden, Norway, Germany, Netherlands, and Denmark. And what they found, very important observation about this cluster headache, it's a severe and recurrent pain attacks. And of course, these attacks lead to reduced quality of life and reduced sleep. And there's high diagnostic delay in diagnosing the cluster headache. And there's increased risk of disability pension on the government part. But they have written also statements in the headache clinics. One patient says that, although I am not in bout, I still fear attacks every day. And second statement given by one patient, I would rather give birth than endure a cluster headache attack. I have some reservation about this statement. Anyway, we'll discuss in the end. So in terms of preventive treatment, we all know verapamil is one of the first line preventive treatment for cluster headache. But what they observed that in RCTs, the verapamil proves that it's more than 75% effective. But in real world, they concluded that it's only 44% for episodic cluster headache and 34% for continuous cluster headache. So there's a disparity between the real world and the lab world. So in the end, they say the lithium and topiramate, again, they are used for their preventive treatment, but they are insufficient support for these two drugs too. So this is a usual pattern of presentation, introduction, basic facts, pathophysiology, semiology, and then my last diagnosis and differential diagnosis. So I'm going to conclude first. It's my innovation for you people. So by word to word, if you call it trigeminal autonomic cephalgia, it's by simple meaning. Cephalgia is the pain in the trigeminal nerve distribution with autonomic features. I tried to fix this cephalgia with the neuralgia, but unfortunately, the neurology does not fulfill all the criteria. So you can say they share some common features. So you can use the word neuralgia form. You just need to tag this thing. It's a neuralgia form, not neuralgia. That is the basis of difference from trigeminal neuralgia, because it does not contain about the autonomic features. This is a major difference. So if you are made clear at this point, so the first thing you need to remember is a TAC is the first prototype, is the cluster headache. Once this cluster headache, then you need to remember two names, Sankt and Sunna. They're very easy to remember. Short-lasting unilateral neuralgiform headaches attacks with cranial autonomic features. This is the Sunna. Short-lasting unilateral neuralgiform headaches attack with conjunctival injection and tearing. This is Sankt. It's easy to remember. And the last is the hemicrania that may be paroxysmal as well as the continua. So out of this box, you need to know at this point of time just three names to remember. First is cluster headache. Second is Sankt or Sunna is the second name. And third is the hemicrania. So technically, the cluster headache, Sankt, Sunna, and as well as the hemicrania, there are three names of the differential diagnosis of any cluster headache. So how to differentiate these three names, cluster, Sankt, Sunna, and the hemicrania? You just need to remember one point. If you are able to identify what exactly the duration of each attack is, I repeat it, if you are able to differentiate or describe the duration of each attack, then you are very easy to say, is it a cluster headache, is it a Sankt and Sunna, or is it a hemicrania? So as we know, duration can be in seconds, minutes, hours, and days. These are four things to remember. So I will explain it for you people. So as we all know, the minimum duration of migraine starts is 4 hours. So it's very easy. Any headache that lasts less than 4 hours is not migraine. And same is true for the TACs. Any headache that lasts more than 3 hours is not TAC. So it's very easy to remember. And the lowest level is, of course, it is only the seconds. If you remember, it's easy to remember. For seconds to single digit minute, I will repeat it, from seconds to single digit minute, either it's the Sankt or Sunna, or it resembles with the trigeminal neuralgia. It's the only for each duration. Then we talk about single digit minute to double digit minute. That is 2 minutes to 30 minutes is the dual duration of hemicrania. And if you talk about 2 minutes duration to 3 minute duration, that is cluster headache. It's very easy. So seconds to single digit minute is either Sankt or trigeminal neuralgia, or single digit minute to double digit minute is the hemicrania, and 2 digits to 3 digit minutes is the cluster headache. And again, I repeat, no headache of TACs more than 3 hours. So it is a minimum duration. So I think I have clear at this point. So let me give you some clue about the cluster headache, because it's a prototype. If you remember this, then rest of things will be very easy for you people. This simple picture is a real depiction of cluster headache. You can appreciate. Everything is so clear, but I will explain. The first thing you need to know, you need at least 5 attacks. There must be at least 5 attacks. And second, the features of attack is they're always unilateral. Each cluster is always unilateral, always. And sphere or very sphere. The third point is their location, orbital, supraorbital, and temporal. And last is, again, I will say repeat. Duration is 2 digits to 3 digits. 15 minutes to 180, and usually it's around about 40 minutes. The third point is there must be presence of 1 or 2 features that are C1 is basically for the autonomic features if related to pain, and second is the sense of restlessness, agitation, they are present. You can appreciate. They are very simple autonomic feature, teary or bloodshot eyes. It's the red eye. Number 2 is swollen or droopy eyelids, you can appreciate. Constricted people as compared to other side. Sweating skin and rhinorrhea. You just need to remember these 5. These are seen in any TAC. Either it's a cluster headache, Sankt or Sunna, or it is a hemicrania. These features will be repeated again and again. Then it's after frequency between 1 every day and 8 per day. And final is they are only best countable for the cluster headache. This is a simple way. So, and next is the paroxysmal hemicrania, you need to remember the two digits, single digit to two digits. This is it. I will not repeat again. These are the same points. You have the same points. These are the same point. Just in cluster headache, you need 5 attacks, but in this case, you need 20 attacks. Rest of things, the cluster was severe and very severe, but this hemicrania, they are severe, and the duration is 2 to 30 minutes. Rest of autonomic features, they will remain same. There's no more difference, just it's again repetitions. So just remember, anything that is conjunctival injection, lacrimation, rhoria, stuffy nose, these all are autonomic disturbances seen in any type of tax. And the most important thing is the hemicrania, the one of the features, they are prevented absolutely by the indomethacin. So it's very confusing. Sometimes you may confuse cluster headache with hemicrania. So you should always remember it's a duration of each attack. If it's a 15 minutes to 180 minutes, it's a cluster headache. If just a 2 minutes to about 30 minutes, it is hemicrania. Rest of features, yes, will be same. Autonomic disturbance will be same. Patient will be agitated, but this is the major difference. And one of diagnostic is the indomethacin. The hemicrania is totally, absolutely prevented by the indomethacin, but it's not true for the cluster headache. The third features is the SUNCT. Again, SUNCT and SUNNA, they are basically, the thing is important. They are short lasting basically of seconds to minutes. Of course, they are the AS tag, they are unilateral and associated with, they are not fulfill the criteria of neuralgia. That's why it's called neuralgia form. They share common features. And of course, they are headache attacks. There's nothing to be remembered, the same thing as in the cluster headache. But only thing is, they are not severe and very severe. They are moderately severe. But problem is that they are very short duration, few seconds to less than a single digit minutes. They constitute the SUNCT or SUNNA, moderate to severe, and their duration is important to remember. This type of pattern can be seen. Patient will say, patient has very severe pain, and then there's a gap of normal baseline, then again patient has a pain, and this is a single stabbing. But sometimes patient can say, patient has pain of 10, then goes back, then again pain, it is called group of stabs. And then there's sawtooth pattern. After 10, maybe 8, 10, 8, 10, 8, 10. This is usually the pattern. But commonly seen, we are experience this type of pattern in SUNCT and SUNNA. And again, the repetition is the autonomic disturbances. But at this point of time, you just need to remember, this is most important. Conjunctival injection lacrimation. It's very easy. All the features are of TAC. Patient experience with conjunctival injection, red eye with lacrimation, you simple call it SUNCT. It's very easy. Short lasting unilateral pain associated with redness of eye and lacrimation, it is SUNCT. And if only injection, red eye is present or only lacrimation is present, not both, you call it SUNNA. So please, it's not so difficult to remember SUNCT and SUNNA in any patient. This is short-lasting neurology from headache attacks. As far as management options are concerned, I will go very briefly. Cluster headache, unfortunately, acute treatment, we can't offer so much for our patients. Usually, oral triptans, they do not work. The simple analgesic do not work. The only good thing is 6 milligram somatriptan as subcutaneous, or it's a nasal, and this is very effective. I have tried a lot of in patients, oxygen inhalation. And in terms of prevention, verapamil, yes, it's a good 360 to 960 milligram. Verapamil, lithium, 600 to 1500, and topiramate. But again, the results are almost 34% to almost 44%. But transitional treatment, yes, we can offer steroids in many patients. And GO and great oxygen nerve is almost used in any type of headache. You name any headache, yes, you can use. As for Botox, yes, you can use in any type of headaches. This is a simple, you can say, blueprint of our cluster headache treatment. But these are, if this is treatable with this treatment, but most of the time, believe you me, patients are usually not relieved with the treatments. So what we can offer them, if they are intractable headaches, Yes, we can offer them some sort of Zumab, and then deep brain stimulation can be used. This is the greater occipital nerve stimulation, sphenopalatine stimulation, and vagus nerve stimulation. They are futuristic for our patient. They are refractory to our medical treatment. Paroxysmal hemicrania, the first line is indomethacin. It is 100% prevented or cured by the indomethacin. And second line you may use other NSAIDs, verapamil, and corticosteroid also be given. And third line is in some patients where the rest of things are failed, you can use the acetazolamide that can be used. So SUNCT is very important. Lamotrigine is a salt that is very effective for SUNCT or SONA. And second line, oxcarbazepine, tryptamide, duloxetine. Third line is carbamazepine, gabapentin, pregabalin. Yes, in terms of transition treatment, ivalodocane can also be used if they're refractory. And finally, greater occipital nerve infiltration with methylprednisolone and lidocaine, it can be used in refractory cases. So as a take-home message, just I will say, you just need to know the duration of each attack. That is very important. 15 minutes to 3 hours, this is cluster headache. 5 seconds to 4 minutes, SUNCT and SONA. 2 to 30 minutes for paroxysmal, and if it's by name definition, the hemicrania means continuum, means it's a continuous pain, it's not episodic in nature. Oxygen, triptans, subcutaneous or nasal can be used for cluster headache. Ivalodocane for SUNCT is acute treatment. Rest of the hemicrania, there is no evidence triptans can't help in these settings. And this is for my own food for thought for you people. And this is basically today's presentation, the end of my presentation. So TAC basically is a trigeminal autonomic cephalgia, is a sandwich between a trigeminal neuralgia and the migraine headache. Is it clear? Okay. Then if talk about the SUNCT and SONA, it's more towards trigeminal neuralgia as because of their very short duration from seconds to minutes. And if you talk about cluster headache, it's as more towards migraine. It's a cluster headache. And in between SUNCT and SONA, the 2-digit minute, 1 digit, 2 digit, 2 to 30 minutes. What's the name of that headache? Hemicrania. So it's very simple. So if you remember these things, the sandwich, you will remember the TAC. I think I left only 1 minute. And the drugs, very simple. Verapamil is you can think of about cluster headache. AEDs, anti-epileptic drugs can be used anywhere. SNRI, serotonin, norepinephrine inhibitors, indomethacin, and as a transitional, you need to remember steroids as well as greater occipital nerve blocks or stimulation. They are the usually present in anywhere. And thank you very much for your patient listening.